Dr. Hemanth, Varshitha. And the next speaker is Dr. Sanjana Thomas. Are you here? Yeah, please be ready, huh? Dr. Varshitha.
Good evening, everyone. Today I'll be presenting on tackling the intraoperative fat prolapse during endoscopic dacryocysterinostomy. Endoscopic dacryocysterinostomy is gaining greater preference over external DCR by oculoplasty surgeons. Orbital fat exposure is a rare complication mainly described post-endoscopic sinus surgery. The proper management is essential to avoid failure of endo-DCR. There is paucity in ophthalmic literature or intraoperative orbital fat prolapse and its management during endo-DCR. In this series, the purpose of this series is to describe the management of intraoperative orbital fat prolapse during endo-DCR. It was a retrospective interventional case series conducted between September 2022 and July 2024 at Narayana Nethralaya, Bangalore. The preoperative lacrimal irrigation, complete eye examination, intraoperative video recording, post-operative endoscopic findings were noted, and all the surgeries were performed by a single surgeon. The prolapse occurred in 3 out of 69 cases. 2 of them were females. 2 had left eye laterality. All the patients had primary acquired nasolacrimal duct obstruction with ICID, that is idiopathic canalicular inflammatory disease, concomitant in 1 patient. The first patient had a sac in sinus morphology with a high-lying sac. The second patient too had a high-lying sac, and the third patient had a posteriorly oriented sac. So the image at the top is the intraoperative image. The image below is an illustration. The pink is the sac, the dark brown is the nasal mucosal flap. So the site of breach was identified. This is the prolapsed fat. It is not being shown correctly here, but this is a prolapsed fat. This part was identified. The fat was repositioned into the globe gently. The opening was approximated with cautery, bipolar cautery, and it was covered by the nasal mucosal flap after fibrin glue application. In all cases, the fat prolapse occurred after the step of lacrimal sac marsupialization in the inferior region of the sac. The prolapsed fat was identified endoscopically by the yellow color, soft and fluffy appearance. In the postoperative period, there was no orbital hematoma or orbital cellulitis, motility limitation, or double vision. All the patients had functional and successful anatomical results at the last follow-up. This is a postoperative ostia at 6 weeks. There is limited documentation on orbital fat exposure during endo-DCR. The reported incidence in endoscopic sinus surgery is 0 to 3.6%, the orbit being mostly breached during ethmoidectomy. The bony lacrimal fossa and the drainage system is closely related anatomically to the ethmoidal air cells. Variation in anatomy of lacrimal sac position with reference to the middle turbinate and agund nesi is well established. A patient from this series had a sac and sinus morphology, while the others had a high-lying sac or a posteriorly oriented sac, indicating close relationship with ethmoid air cells, increasing the possibility of fat exposure. Various methods of recognizing the exposed orbital fat have been described, which include the eye press test biopsy. In this series, it was identified with its soft and fluffy appearance and the color. So intraoperative management described so far include nil intervention using bipolar cautery to reduce the fat, covering the area with hemostatic agent or silastic sheathing. In this series, a simple and effective way has been described to prevent failure of endoscopic DCRs and other orbital complications. Concluding, repositioning of prolapsed fat into the orbit followed by closure of breach by bipolar cautery and covering the area with nasal mucosal flap is an effective and easy way of managing intraoperative fat prolapse during endoscopic DCRs. A high-lying sac or sac and sinus type of morphology should alert the surgeon of a possible risk of orbital fat prolapse intraoperatively. These are my references. Thank you.
These surgeries were done by ENT surgeons or ophthalmologists?
The surgeries were done by me, ma'am.
So fat prolapse is basically a complication of endoscopic DCR.
Yes.
Because that means that you have gone beyond the, the posterior lacrimal crest.
Yes, so the,
So any extra precaution you would like to take once you see the intra-op, fat prolapse like this? Any additional advice to the patient?
uh, no additional advisement, routine post-operative medications were given. And
Patient has to avoid Valsalva maneuver. That is very important thing.
pardon, ma'am? Sneezing.
Sneezing,
Yes, yes.
blowing. This is very important instruction which you have to give. And the other thing is oral systemic antibiotic.
Yeah, all the patients were given oral systemic antibiotics, and in the routine post-DCR patients, all of them are advised not to exert, not to lift heavy weights. So that is a part of the routine DCR post-operative advice given
Yeah,
to
that
them.
is routine thing. But
Yes.
in addition to the routine thing, you have to emphasize that
Yes,
also.
ma'am.
Any comparative studies with the external DCRs and endonational DCR with this fat prolapse problem?
No, ma'am. So that is the limitation. There is paucity in ophthalmic literature. In the ENT literature, it has only been described post-endoscopic sinus surgeries. So post-DCR surgeries, though many people have encountered, it has not been documented uh, in literature.
And sinus surgeries, I've seen many of ENT surgeons crossing the limits, entering the orbit and damaging the orbital fat, damaging the optic nerve, causing
Medial rectus also, yes.
medial rectus, and so many they are doing with with sinus surgeries.
Yes.
But I recommend external DCR in all the cases, not endonational. I am very, 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 very much against all this. Okay.